Hi everyone, my name is Allison Weiss and this is my evidence-based change model project. For this project, I chose to use the Iowa model of evidence-based practice. This model focuses on the entire healthcare system all the way from the patient to the provider. Step one is to identify if there is a problem that needs change within the healthcare system. Step two is to determine if that problem that has been identified is a priority that needs intervention in the healthcare system. Step three is to investigate the current research and evidence that has already been discovered about that problem. And step four is to evaluate the merit of that research that was being studied. Step five is to create a pilot program of practice change and implement the change at a small scale and work with an interprofessional team and determine if that pilot worked well. And if it did, step six is creating the pilot and sharing it at a larger scale within the healthcare system. There are some key assumptions of the Iowa evidence-based model. The first is determining that there's a problem within the healthcare system and then prioritizing that problem. The second major assumption and major component of this model is to evaluate the evidence and critically appraise the quality, the merit, and the validity and how applicable that research is to the project. And after it has been critically examined, then the pilot program can be developed. And another major assumption and component of this model is interprofessional teamwork and collaboration. They believe that it takes a village to implement a great program and not just a couple people. And this model also believes to start with a pilot program and implement the change at a small scale. And once it's been successful and the kinks have been worked out on the small scale, then it can be a change that is made at large. I believe that the Iowa model is a great model for my particular project. So the identified problem that I have found is poor HPV vaccine uptake and decreased parental education. Through all of the research we've done so far in the course, I have discovered that there is a significant decreased understanding of HPV, especially among parents. A lot of parents believe that males don't need the HPV vaccine. It's very sexualized and gendered vaccine, thinking it's only for females and it's only for sexually active adolescents when that is not the case. I have found a lot of evidence that parents might not even know that HPV is related to cancer and not just cervical cancer, but oral and pharyngeal and other types of cancer as well. And a lot of parents also didn't know that HPV is one of the major causes of genital warts. So the evidence has shown that that is a major barrier to people getting vaccinated against HPV. Some of the other studies have shown that the stronger the provider recommendation to get vaccinated, the increased chance that the parent will agree to their child getting a vaccine. The CDC reports that rural communities have a decreased vaccination rate, and education as an intervention has shown to improve vaccination rates. Parents have a lot of misconceptions about side effects, age of getting vaccinated. They think that 9 years old is way too young for a child to need a sexual oriented vaccine, even though it provides a really long window of protection once that person were to become sexually active. And it's not just something that'll kind of protect them from genital warts, but can protect them from cancer later. And a lot of parents had a hard time understanding that. The model emphasizes the need for teamwork. This project would not be possible without a teamwork model. So this project would involve providers, nurses, medical assistants, and a lot of other people. And this model assumes that a pilot intervention should be tried first before implementing a larger scale project, which I think is really great for this type of project because you can determine what worked and what didn't, and maybe parts of my proposal won't be as effective as I would hope, and you can go back from square one and start over during your pilot phase versus if you already involved mass amounts of parents and mass amounts of workers. So, applying my project to the Iowa model with the steps that I talked about earlier. Step 1, the identified problem is poor HPV vaccine uptake and poor parental education. This is a priority in the healthcare system because HPV is very, very prevalent in all communities in the United States, and the vaccination rate in rural communities, such as in West Virginia, is very poor. And the evidence has demonstrated that there is a significant educational gap in rural communities. Steps 3 and 4 is to investigate the current research and evidence, which I've been able to do with this course so far, and the research has significantly shown what I mentioned earlier, all the misconceptions, and showing how few parents understand HPV and the vaccine, and the evidence from the CDC showing that rural communities are experiencing the gap larger than urban communities. Step 5 is determining if the research was reliable and valid and of quality merit, and in previous coursework I have been able to determine if the research was of good quality. And step 6, it would be me implementing the proposal during a pilot program. As I mentioned, the Iowa model has served as a great guide when developing the steps of my project. I started by picking the problem and prioritizing it, so I chose poor HPV vaccine uptake and poor parental education of HPV, and I have conducted research in previous coursework and have found that this is a significant problem in rural communities, and parents have a lot of misconceptions about HPV and the vaccine. I have, in previous coursework, determined that the sources that I've used and the research studies that I've read are of great quality and great merit. And the next step of the project would be the pilot program. If I were to go through with the project and the proposal, I would implement the pilot program on a small scale. If something fails, we would go back to the drawing board and determine what went wrong, what should we change, and what could we do next to make it work. If the pilot is successful, a larger rollout could be implemented with the intervention being used at large. The intervention and pilot program of this project is feasible based on my organizational readiness assessment that I did with one of my previous preceptors. The location is very receptive to quality improvement projects and doing anything that can make the community better. The cost of this project is pretty minimal. I talked about parental education and also giving them a pamphlet, because some of the studies have shown when a parent has dedicated time and something to read regarding a vaccine, that they were more likely to vaccinate their child. So the cost of a handout is very minimal, less than $1, usually just a couple cents. And that would change based on it being black or white and the graphics used. And training the provider and nursing staff would take some paid time. I would anticipate it wouldn't take more than an hour to talk about the implementation of the program, the logistics, how to document in the health record if they got HPV, and implementing the parental education, just going over how the project will work. And the extra time at the office visit with the parent and enrolling them in the program and doing the intervention may decrease productivity in the office, so that is a risk that there would be. As I mentioned, the training would be completed in probably an hour, and I would also want to share with the nursing staff and the providers all the evidence and the rationale for the project and why the project is important and why we're doing what we're doing, and also discuss with the providers the education that comes on that pamphlet that would be handed to the providers, and how to document the vaccine appropriately in the health record, and also talking with the providers on a script of what to talk about with the parents and how to properly talk about it so that all the providers are providing the same education to all the parents during the project. The priority expected outcome is increased parental education and increased vaccine uptake. Secondary outcomes might be provider adherence, workflow, health record documentation, series completion, and determining factors that are limiting HPV uptake, such as cost. So this project is set up like a quasi-experimental research study. Prior to the beginning of the study, the practice would evaluate baseline HPV rates in their office. And prior to the study, the parents would complete a questionnaire or survey about why their child isn't vaccinated against HPV and maybe explain some of the barriers that they have faced, such as cost and accessibility. And also, the survey would reflect their thoughts and ideas about HPV prior to the intervention so that there's a baseline understanding of the parents' thoughts on HPV and the vaccine prior to the educational intervention so it could be measured. We would also only include parents and children who have not been vaccinated against HPV. If they've received the vaccine, then they would not qualify for this project. And if they are participating in the project and they're not vaccinated, it would be great if the survey could include a reason why that child hasn't been vaccinated yet and determine other barriers. Maybe it's because the provider has never brought it up in a appointment. So if the parent agrees to being in it, they would get that survey. After that, and they agree to be in the project, the providers would use the script to go over with the parent HPV education and side effects of the vaccine, benefits of the vaccine, causes of cancer and genital warts being HPV, and how the research and evidence has supported that the HPV vaccine is really safe with minimal side effects. The setting would be completed in a primary care pediatric clinic at a school-based setting. And the population is aged 9 to 17 at well child visits or follow-up visits on children who are not up to date on the HPV vaccine, specifically those who have not gotten a vaccine and especially who have not completed the series. The intervention is a strong, standardized HPV recommendation from the provider with a provided pamphlet to the patient. Following the intervention, the parent will fill out a survey and they can agree to getting the vaccine on site, making it really easy. They can receive the education and then receive the vaccine on site at that same office visit. Or if they want to go home and think about it and read that pamphlet, they can return at another time. So we'll have post-survey right after the intervention and then again 6 months later to determine if their reasoning has changed and see if that child got vaccinated within that 6-month period. And the data would be significantly, fairly easy to follow in the health record because if the child gets vaccinated for HPV, it should be documented at their primary care office where the project is being done. The most obvious and important impact is increased patient vaccine uptake of HPV and preventing these patients against genital warts and all kinds of cancer. The higher the vaccine uptake, the more cancer prevention and improved livelihood and longevity that patient might be able to experience. And series completion rates would increase in HPV, and increased parental knowledge and acceptance of the vaccine would go up, and there would be reduced parental hesitancy of getting their child vaccinated. The second outcome impact regards the provider and reducing missed opportunities to talk about HPV and the HPV vaccine, and also the providers having the ability to provide consistent and accurate education across the board to the parents. The last is public health. So, preventing cancer is a public health initiative, and it's in Healthy People 2030. So, increasing vaccination rates will also decrease genital warts and types of cancer and the bad HPV strands, hopefully, in the community, and promote increased vaccine coverage. I was very pleased with the Iowa model. I really like how it gave you step by step what to do, starting with something small, like determining the problem, determining if it's a priority, and then doing the research. And you kind of can go back and forth. You determine the problem and you determine its priority, but the research just isn't there. Then you can go back to the top. So I really liked that. You can just follow the steps. And I like that the Iowa model recommends doing a pilot intervention and pilot program first so that you can do it on a small scale. And I think it's easier to mess up a intervention or a project in a small group versus if we implemented something at large and it fails, then a lot of factors could have gone into why that failed. Where if we have a small pilot study and we do that first, then maybe we could figure it out and eliminate confounding variables easier in a smaller controlled setting. And I liked that the pilot project is done first. So if you want to perform a larger project, then you've already got the bases covered from the smaller one you did. I believe that the model is realistic and evidence-based and can be used in a lot of intervention studies.